Hi there, it's Matt here, and welcome back to the podcast. Today, we're going to be exploring the critical topic of prescription sleeping pills, and we will delve into what sleeping pills are, how they work, the different classes of these medications. We'll speak about their benefits, and we'll also speak about their side effects, their risks. And at the end of this episode, what I simply hope that you have is a more comprehensive understanding both of the mechanisms that underlie these sleeping pills, how they work, in other words, and also the types of considerations that you may wish to have if you want to reach out to your doctor and think about their use. I couldn't do this topic justice by myself, so today I am joined by a fantastic guest, Dr. Ranji Varghese. He is a distinguished expert in sleep medicine, and Dr. Varghese is the medical director at the Minnesota Regional Sleep Disorders Center. He received his degree from the University of California, Irvine, and he completed his residency in general psychiatry at the Mayo Clinic in Rochester, where he also served as chief resident. He holds double board certifications, both in psychiatry and in sleep medicine. His interests are so wide-ranging, from neuroscience, consciousness, the relationship between sleep and mental health. He's also an assistant professor of neurology at the University of Minnesota. And you'll see, based on his nature, he's such a lovely guy, just wonderful, empathetic sensitivity. You'll see why he's been recognized as one of the top sleep doctors by Minnesota Monthly. Welcome to the show, Ranji. It is such a privilege to have this chance to both interview you and your quite brilliant mind on this topic that, as I said, I have just had so many questions on over the years. Perhaps you could not only share some of your background about you and your ascent into your brilliance within the sleep field, but tell me and the audience a little bit about how you got into the field of sleep. And even though I've mentioned your brilliance at the start of the show, say a little bit more about your expertise in sleep medicine that, of course, I know, but people listening perhaps won't know. And please, because I know that you are incredibly modest, please don't be shy, don't be humble here. Tell me a little bit more and tell the audience a little bit more.
You're too kind, Matt. Thank you. Brilliant. I'm not sure, but I really, really appreciate it. It's really an honor to be here with you and for you to provide me a platform to educate listeners and, really educate listeners on scale. When I was a medical student, I was fascinated by human behavior and the human brain, which is really what drew me into the field of psychiatry. By the time I arrived at Mayo Clinic as a psychiatry resident, I really had no clue sleep medicine existed as a separate field, partially because in medical school, I don't remember having a single lecture on sleep. That's changed, thankfully. But at Mayo, I received a lecture on sleep and wake circadian rhythms and found myself just absolutely riveted. And that fascination led me to the wonderful world of sleep and how so many different disciplines, including the neurosciences, physiology, psychology, intersect in this discipline. When I begin to appreciate this mystery that we call sleep and how crucial it is for our well-being, I was hooked. Particularly at our center, the Minnesota Regional Sleep Disorder Center, we have a strong curiosity for the parasomnias, particularly REM Sleep Behavior Disorder, which, as you know, was identified at the center by Dr. Schenk and Dr. Mahauld.
Those parasomnias, Raji, those are a collection of sleep disorders, sort of that almost, as the word describes, they sort of sit around this thing called sleep, but it's not quite that the person is sleeping. Maybe just very quickly unpack that, because I didn't want to interrupt you. I want to continue to hear more, but just for folks who don't know the parasomnias.
That's exactly right, Matt. They represent these non-ordinary states of consciousness. They're the superposition of different states of wakefulness and sleep. So you may engage in wakefulness behaviors while, almost partially or fully asleep. It's like a liminal space, if you will. It's utterly fascinating to me. And also, in the last few years, I've had the privilege of working with psychedelic medicines, which also straddle these non-ordinary states of consciousness. So at the end of the day, though, the best part for me is that I get to work with wonderful colleagues to help people recover from crippling disorders, including sleep apnea, narcolepsy, insomnia, and they feel better. They get to live their life fully, and that couldn't make me feel happier.
It is a fantastic service that you provide these people, and what a wonderful, wonderful emergence and fascination that you have with sleep. I can just tell when I first saw you present at a conference, you can just tell those people like me, just obsessional about sleep. It's just, you're just nuts about sleep, and it never goes away. Once you're captured, that love affair, you're locked in. So let me move on to this topic. And by the way, folks, just as a high contour level right up top, I do want to mention that Ranji has no disclosures. He is not paid or is not representing any pharmaceutical companies here. And I think that that's really important, just to be able to affirmatively state upfront, and for people listening just to know that the information that you're getting here from truly one of the best in the world is not going to be colored or altered by any of those trappings of associations. So without further ado, sleeping pills is the topic. At the 30,000 foot view, perhaps we can even just answer the question, what are prescription sleeping pills? What are they, and how are they used to treat sleep disorders?
Sleeping pills are a class of medications that are prescribed to help initiate sleep or stay asleep. So these medications are commonly used to treat insomnia, which is a condition described as an ability to fall asleep or stay asleep. So, for example, people that have difficulty with the start of sleep, a short-acting sleep medication can be used. For others that may have difficulty falling asleep but awaken multiple times and can't get back to sleep, we can prescribe a longer-acting medication at the beginning of the night. There are different classes of sleeping pills with different durations and modalities that clinicians use to fit what the needs of the patients are.
And so, in some ways, it's a wonderfully precise, specific answer, which then almost begs the question, why them? Why are they prescribed over, let's say, other forms of treatment for sleep disorders?
Yeah, Matt, that is a really good question because we use medications, sleeping medications, only when other treatments fail to work or can't work practically. So, first, we try and identify the reasons people have difficulty getting to sleep. For example, some patients may have restless leg syndrome, a very bothersome discomfort in the lower extremities that primarily affects them at night as they're trying to lay in bed getting to rest. Addressing the RLS or the restless legs might fix the sleep initiation difficulties. For maintenance insomnia, so for example, people who suffer from obstructive sleep apnea, they often wake up in the middle of the night multiple times and sometimes can't fall back asleep. So treating the obstructive sleep apnea would likely fix that sleep maintenance insomnia. Additional examples include improving people's sleep hygiene or addressing underlying mood or anxiety disorders. But sometimes we do use sleeping medications for very specific reasons. For example, if we anticipate that the insomnia will be short term, i.e., during periods of stress that are time limited, a short quantity of sleeping aids could be useful. Sometimes sleeping medications could be delivered safely to people, say, that have to travel to different time zones. Sleeping medications can also be used for people that are shift workers. For example, an overnight worker that arrives home in the morning and tries to sleep during the daytime. They may not be able to achieve a good 7 to 8 hours of sleep without the use of a sedative. So we try and address these conditions first and foremost. But when we identify that patients have an insomnia that has evolved over time and has become very stuck, we recommend cognitive behavioral therapy for insomnia. And cognitive behavioral therapy for insomnia is the gold standard therapy for chronic insomnia and is really delivered by trained professionals to retrain the brain and body to reassociate the sleeping space, if you will, as a place for sleep and not for a place of being awake. If these measures fail, we do turn to medications to help individuals. At that point, we're really doing this to reduce misery because insomnia can be miserable. And we know that a significant lack of sleep can be detrimental to our overall health. I'll give you a good example of this, Matt. I work at a wonderful hospital in the heart of downtown Minneapolis, and we see people from all walks of life. Some have resources to access cognitive behavioral therapy through our center, and some don't have those resources. So, say, for example, a single mom that works two jobs and has significant difficulty with initiating sleep. Cognitive behavioral therapy may not be a practical option for this individual. And so sometimes my job is to palliate the misery with sleeping medications.
And so, what you're elegantly describing here, I think, is that tension that I often hear in when people speak to me about their sleep. How do you, as a physician, make the balanced decision between advocating for cognitive behavioral therapy and, as I've spoken about on this podcast many times before, it really is considered the first line recommended treatment for primary insomnia, that sort of really stubborn situation, absent of the other things that you just described. But there are also situations, and you described one there with perhaps a mother who does not have access to cognitive behavioral therapy for insomnia or CBTI. But you could also imagine that there are individuals for whom, when you describe the process of CBTI and going through it, they just say, honestly, I just know in my heart of hearts that I'm not going to be adherent to that kind of an intervention. It's just not going to be for me. So, what can you do for me? How do you, as a physician, try to think through that problem where someone, it's very clear that medicine says the first line treatment would be non-pharmacological CBTI, not sleeping pills. But they say, I just know I'm not going to be adherent to that. Is that once again an alleviation of suffering decision where you listen to the patient and you hear what they're saying? How do you square that circle?
Yeah, this is sort of the art of medicine where you have to sort of meet where the patient is. And, sometimes what I like to do is try and engage folks in motivational interviewing or motivational enhancement and try to understand perhaps the reasons why they may feel that this is not a process for them. And as you mentioned earlier, if patients don't have the motivation for CBTI, which really is a rehabilitative process, it's really setting them up for failure and not for success. So where I leave it is talk to them in that way. I said, CBTI is the recommended treatment. I know that you are struggling with this, but I try and continue to push them along little by little along that way. Sometimes it works, sometimes it doesn't. Sometimes people are frustrated. But at the end of the day, I have to make a decision on whether medications are correct for this patient because my first and foremost duty is not to harm people.
And so, with that said, and with this show in particular, I not only love the clinical descriptive communication of the science, but also the mechanistic communication of the medicine and the science. So perhaps I can just change the narrative a little bit and ask questions about, or a question, which is, how do prescription sleeping pills work? In other words, could you, at a high contour level again, maybe just explain the mechanism or mechanisms of actions of sleeping medications? And of course, we know that we're going to, in this episode, we're going to really dig deep into the individual medications, but could you just give us a high level overview of the mechanistic actions?
I think we should discuss the basic model of how we conceptualize the process of sleeplessness, I should say. Most problems of sleep is not the brain's inability to sleep or that the sleep mechanism is broken, but it's a problem of the brain being in a hyperarousal state. And thus, the brain's natural ability to sleep is overdriven by this overactivity of the brain. It's as if the brain naturally wants to slow down and sleep, but the gas pedal is being pressed down at the same time, disabling the sleep system to take over. Largely, what these medications do is they press the brakes a little harder to override this hyper arousal to induce sleep. Some of these medications block the excitatory neurotransmitters or enhance the inhibitory neurotransmitters. And some of these medications affect our endogenous hormone, our melatonin receptors, to activate our natural circadian rhythm, allowing us to fall asleep a little bit earlier. So that's a very simplistic description of what are probably more complicated circuits, but I think it may suffice for our understanding.
So that's a description of essentially what we think is happening conceptually, or we seem to know is happening conceptually, about this overdrive of wakefulness atop of a mechanism of sleep that is still effective. But perhaps you could then paint a picture of the individual neurochemical characters in this play, in this narrative of sleep, and specifically sleep medications, and maybe even describe, if you can contort my question sufficiently, to say a little bit about some of the side effects and how those mechanisms and the cast of characters could also lead to side effects as well as their efficacy, their effectiveness.
Absolutely, yeah. Our brains contain a lot of excitatory neurotransmitters, including dopamine, histamine, norepinephrine, and a very specific and wonderful neuropeptide called orexin, which stimulates the brain and promotes wakefulness. Reducing any of the activity of these neurotransmitters can help slow brain activity and thus induce sleepiness. Conversely, there are inhibitory neurotransmitters, most notably something called GABA, or gamma aminobutyric acid. Enhancing the effects of GABA can also slow brain activity, leading to drowsiness. Another mechanism includes medications that interact with receptors for melatonin, our natural sleep hormone. And as we interact with those receptors, it can signal to the brain that it's time to sleep. It may not be necessarily sedating, but it's a signal to the brain to sleep. There are other medications that are on the market that have sedating properties, like muscle relaxers, opioid medications. And of course, alcohol is the number one thing that people use to help them try and get them to sleep. But of course, they are rarely recommended for sleep, especially due to their undesirable side effects and long-term consequences. I think mentioning side effects early on in this discussion is very important, Matt. I mean, the consequences of not being fully awake and feeling drowsy can lead to a number of different potentially catastrophic conditions. That includes falling, cognitive impairments, being unable to, let's say, operate motor vehicles, apart from physiological symptoms like dry mouth or urinary retention. So while these medications, of course, have their benefits, there's no free lunch and there are side effects.
I am so glad that you bring this up, because it's something that I hear all of the time from individuals too. Of course, when you are not sleeping, you are so desperate for sleep. There is such a strong desperation that you will almost wish for, near demand, something that is going to help you fall asleep. And that's very natural and very understandable. But we tend to forget that these things do come with non-trivial side effects, and some of them can be really non-trivial. Thank you for bringing that up. A long-standing partner of today's podcast is Element, spelled LMNT. Element is a sugar-free electrolyte mix. And for me, it was the sugar-free part of that made me start using it quite some time ago. Beyond having the electrolytes in the right balance, the other reason I'm a fan of Element is that it's scientific. And if you look at the people who created the company, you'll find some pretty heavy-hitting physiology, biochemistry, and pharmacology knowledge that is baked into the product. And again, all of that comes without any sugar. I am a devotee of their product. I really do use them. I know people will say that on these ad reads. I use it every single day for my workout. I put it in my protein shakes afterwards. I do use it. Also, by the way, Element has just recently brought back the chocolate medley range, which you can have essentially your electrolytes hot. And in the trio of flavors, there is chocolate mint, chocolate chai, and also my favorite, chocolate raspberry. And by the way, I happily badgered them to agree to give you fine folks a free sample pack with any purchase of Element if you just use the link lmnt.com/Matt Walker. That's lmnt.com/Matt Walker. With all of that said, let's now get into specifics. Let's speak about the different classes of sleep medications, how they work, their pros, their cons. And here we're going to really focus to begin with on two major classes: the older first generation sleeping pills, which are what we call the benzodiazepines. And then we'll come on to essentially the second generation of sleeping pills, what we call the non-benzodiazepine sleeping medications. So let's start though with the first emergence of sleeping pills more generally in the field of sleep medicine. That was the benzodiazepines. What are they? And can you provide some examples and just add some flesh to that very diminished bone of what are they?
You're correct. I mean, really, the barbiturates and the benzodiazepines. The benzodiazepines are a class of medications that are used for various clinical purposes, including managing sleep disorders or anxiety disorders, such as panic disorder, generalized anxiety disorder. They can be used very well for muscle relaxation, for anesthesia, for seizure control, among other uses. And common benzodiazepines include temazepam, or what we call Restoril, lorazepam, or what we call Ativan, alprazolam, called Xanax, diazepam, Valium, and clonazepam, or Klonopin. And although all of these benzodiazepine medications have a similar mechanism of action and act on the same brain receptors, they bind differently to specific sites on these receptors, resulting in varied effects. For instance, some benzodiazepines might be more sedating, while others might provide greater anxiety relief or muscle relaxation. Therefore, really the choice of benzodiazepine is often based on its specific effects and the therapeutic benefits needed for the patient.
And so, how do then these older generations, these older benzos, how do they work to induce this thing called sleep? And I'm sure we can argue about truly whether it is natural physiological sleep or is it a form of sedation. But tell us a little bit about how those work mechanistically within the brain to induce this state of sleep.
I agree with you, man. I think that is sort of artificial and it's not our natural sleep. And that's why I really recommend people trying to achieve a natural state of sleep and why we only use these medications if absolutely needed. But generally, benzodiazepines work by targeting specific areas in the brain, what are called GABA A receptors. And so when a benzodiazepine medication binds to these GABA A receptors, it alters the shape of that receptor, making it more receptive to a neurotransmitter known as GABA. Now, I'm introducing it GABA here because it's really important to mention GABA. It is the main inhibitory neurotransmitter in the brain. It is essentially the key ingredient that the benzodiazepines try to enhance to slow down the communication between neurons in the brain and subsequently slow the activity of the brain. Consequently, this leads to the sedative and anxiety reducing properties of benzodiazepines.
And so essentially that GABA chemical, when it is released in the brain, is a red stoplight. It's a red traffic light in the brain to say, halt the activity, slow it down. And what we're seeing here, as you're describing with the benzodiazepines, we're really enhancing the activity of that GABA system in the brain. And would you say that that's mostly targeting the cortex, or are we talking about sort of broader brain shutting down, just so folks know, or how well understood is that?
Yeah, I think it's affecting the thalamus and the cortex to a large degree. So we see this diminishing of activity, particularly in the cortex. And as you mentioned, it's like a stoplight. The metaphor that I use is it's like we're pushing down on the brakes of the car so that this hyperarousal state can't override.
I'm really grateful that you mentioned the thalamus there too, and it's something I fail to mention enough of on this show. I've mentioned it a little bit before. The thalamus, it's almost like this sort of miniature little orange that sits in the middle of the brain, and it essentially acts as a sensory gateway. All of the sensations flooding into your brain, they flow through the thalamus, which is the sensory gate. And when it's open, those signals are allowed free passage up to the cortex, and the cortex processes all of them. And we have this thing called conscious perception, which is a critical part of wakefulness. But when the GABA system becomes more active in its entrapment of the thalamus by way of these benzodiazepines, the sensory gate to the external world essentially is closed tightly or closed tighter. And as a result, the sensory signals don't get up to the cortex as much. So we stop perceiving the outside world, and therefore we have a diminished state of consciousness. So thank you for describing that. Then to the question, I suppose, what are the benefits? And I suppose that if they are not recommended as a first line prescription agent commonly in sleep medicine, maybe we don't have many benefits left, but tell us if there are. But also, what are the risks associated with these older first generation benzodiazepine sleeping pills?
There are benefits for people that are suffering, but the main benefits for people that use benzodiazepines cautiously can attest to its anxiety reduction properties. So, for people that suffer from panic attacks or people that have generalized anxiety disorder, which can be crippling, they can help calm the ruminating thoughts or even the muscle tension that go along with that anxiety. And as I mentioned, they can also be helpful for muscle relaxation. For example, people that may have spasms due to muscle injury or people that suffer from cerebral palsy that have spasticity, these medications are exceedingly helpful. Benzodiazepines are all very commonly used to help in breaking seizures. I remember when I was at Mayo Clinic, I was in the neuro ICU and seeing a patient seize in front of my eyes and just pushing lorazepam when within a few seconds, sort of breaking the seizure. So very important in that setting. They're commonly used in medical procedures due to its amnestic effect, which we'll talk about at some point. So people can't remember the trauma of the procedure itself. Benzodiazepines can also be helpful for people that have withdrawal effects from using alcohol heavily, assisting in detoxifying from alcohol withdrawal safely. Another benefit to some of the benzodiazepine as it relates to sleep disorder is its very potent effect in treating restless leg syndrome, which, as you know, can make it exceedingly difficult for people to fall asleep. And so, of course, we use them routinely to help individuals that have not been able to successfully be treated with other methods to help them get to stay asleep or initiate sleep. And there's a double-edged sword to this here, right, Matt? That the risks of using these medications may have their benefits, but the side effects can be mild to potentially catastrophic. So
Yeah.
let's talk about that. One of the risks, of course, of using benzodiazepines includes becoming physiologically dependent and addicted to these medications, which is why we try and use these medications for short periods of time, because abrupt discontinuation of these medications can lead to withdrawal symptoms, which, of course, is another risk. Another risk, of course, includes interaction with other medications. Benzodiazepines taken with alcohol or opioid medications can increase sedating effects, leading to potentially catastrophic respiratory failure, particularly in sleep. So, a good example may be patients that have untreated severe obstructive sleep apnea who also take benzodiazepines. They can have some very serious hypoxic events, not only from the obstructive sleep apnea, but with the co-administration of this benzodiazepine and their untreated sleep apnea.
That's not a trivial thing either, considering we think, and you tell me, but maybe somewhere between 60 to even 80% of individuals with sleep apnea are currently undiagnosed. So that's the danger if they are mixing those two things together and they're not aware that they have a clinical diagnosis of sleep apnea. The danger only increases manifold in that possibility. So I think it's a really important point to bring up.
Yeah, it's not trivial. And we have to include alcohol in that process. Alcohol binds to the GABA A receptor, and these folks that are untreated, they're at higher risk for these potential complications. So thank you for pointing that out. Benzodiazepines additionally make us feel unsteady on our feet. They can make us feel dizzy, and they thus increase the risks of falls leading to major injuries. So we're really careful when we prescribe these medications to people who already may have stability issues or our aging patients. I mean, we do not want our aging patients to fall and break a hip, because that is the start of a cascade of events that may eventually lead to very bad things downstream. When we think about benzodiazepines and how it affects our brain and our cognitions, there's good data that it can cause cognitive impairment and maybe memory and attention issues. I have to say that there is some data that suggests that people with chronic insomnia and short sleep due to their insomnia that are also at higher risk for long-term memory impairment, and correcting the sleep issues with benzodiazepines or benzodiazepine receptor agonists may actually be protective for that. There's a 2019 study that looked at that. But again, these are large population-based studies, not perfect study designs. Another potential side effect of benzodiazepines are what we call complex sleep-related behaviors and anterograde amnesia. Complex sleep-related behaviors are behaviors that are engaged while mostly asleep or partially asleep. These can include things like sleep-related eating, somnambulism or sleepwalking, and the amnestic effects of benzodiazepines essentially makes you forget what you've done, almost like an alcohol-induced blackout. So lastly, I'd like to say these medications, when taken in an overdose situation, can lead to death. So I can't stress enough how important it is to have a thoughtful and informed conversation with the person before prescribing these medications.
It really is absolutely critical. And I hope people take that list of side effects in the sober manner with which we all should respect them. And considering that list of side effects, tell us a little bit about how the use of these first generation older sleeping pills, these benzodiazepines, has evolved and changed over time in the treatment of sleep disorders.
It's really funny because medicine changes over time as we learn more things. It's important to be mindful of the risks associated with using benzodiazepines for sleep. But initially, when these medications were widely used, they were widely prescribed because they were effective at promoting sleep. As awareness of their potential risks grew, there was a significant shift in how they were used and how often they were used. And so currently, we've adopted a much more cautious and informed approach. Specifically with benzodiazepines and any sleeping medications, they're now typically used as short-term solutions for sleep issues. They can be useful for patients experiencing acute anxiety during stressful times. And like I mentioned earlier, despite the availability of various treatments, some individuals still require benzodiazepines to help them sleep. But really, we start low and go slow with these medications, a very cautious approach compared to when they were first introduced.
So then, if that's the emergence of what we now think of as pharmacological insomnia treatment in a substantive way in medicine, then came a second wave. And that second wave was a wave of medications that I think most people listening to this will be familiar with from a colloquial standpoint, which is the non-benzodiazepine hypnotics, things like Ambien, Lunesta, Sonata. So let's move into that second wave of sleeping pills and the non-benzos. What are these non-benzodiazepine sleeping pills, and how do they differ from benzodiazepines? Because they've both got benzos in the name, and maybe They play on mechanisms that may or may not overlap. Help us unpack and understand this difference between these two classes.
When we think about the non-benzodiazepine sedatives, we're really referring to the benzodiazepine receptor agonists. They work just a bit differently, and they represent the second generation of sleeping pills, as you had just mentioned. What's interesting is while these benzodiazepine receptor agonists, or sometimes called Z drugs, when they bind to the GABA A receptor and increase GABA transmission, remember GABA being that neurotransmitter that calms the brain down, they don't necessarily have some of the baggage, if you will, like the benzodiazepine. Some of the differences is they may not have the same anxiety reducing effects like traditional benzodiazepines. They're very much more specific to promoting sleep and maintaining sleep. And so there's a nice advantage to having medications that may be a bit more focused rather than the benzodiazepines, even though they're binding to the same receptor. They're very interesting and they're very focused. They're very useful compared to the benzodiazepines.
So, in some ways, it's a subtle mechanistic difference, but it turns out as a result to produce very non necessarily subtle differences in effectiveness, in some side effects that we'll discuss. Before we get there, though, maybe could you go into a little bit more detail into some of the common names of these? So, the Ambien, Zolpidem, Zopiclone, Lunesta. Could you maybe just unpack any of these Z drugs that you wish, just to go into a little more double click detail?
When we think of these drugs, they're really working similarly, but the duration of action is really the difference between the three. So let's start with the first of the Z drugs, as they are sometimes called, like I mentioned, that came on the market was Zolpidem, or commonly known as Ambien. It is the most widely prescribed sleep aid in the United States and FDA approved for sleep onset insomnia. The second medication is called Zaloplan or Sonata, which is also FDA approved for sleep onset insomnia. This medication, as compared to Ambien, has a very short duration of action. So it's very useful in helping people initiate sleep. So if patients are able to get to sleep, but they have this middle of the night awakening and can't fall back asleep, we might be able to use this Zaloplan, which has this very short duration of action, to help them get back to sleep so long as they have enough hours left to sleep so that they don't have a hangover effect in the morning. Lastly, there's a medication called Izopiclone or Lunesta, and it is also FDA approved for both sleep onset insomnia and also sleep maintenance insomnia. And this medication has a longer half-life, and so the duration of action is longer, which makes it useful for people that have difficulty with sleep initiation and sleep maintenance problems. So how I like to remember it, or how I teach my sleep fellows, is Sonata, shorter, Lunesta, longer, and Ambien is the middle, where it's just a little bit longer.
So we've got these three Z drugs that you described, and they've got these fascinating different characteristics. There, you're sort of defining them on the temporal duration of their action in terms of a classification difference. What makes them different in terms of their mechanistic action? Do we know much of anything about how and why they are subtly different despite being overarchingly under the same categorical umbrella of being a non-benzo Z drug?
It's a really good question. And as you mentioned, they are very similar to the benzodiazepines in that they bind to this GABA receptor, inhibiting brain network communication, which of course allows for the sedating properties. There are some PET or positron emission tomography studies or brain imaging studies that have shown that the administration of Izopiclone in particular shows a rapid decline in metabolic activity in specific areas of the brain responsible for arousal, which you can interpret that these drugs might be reducing the hyperarousal state, which is often seen in insomnia, in addition to sort of enhancing the sedating properties of the brain as well. Additionally, I think compared to benzodiazepines, these classes of medications have a minimal effect on delta wave sleep, also known as slow wave sleep, which, of course, as you know, is important for growth, memory, immune function. While in contrast, benzodiazepines are known widely to reduce delta wave sleep. There's some advantage there. But as you mentioned earlier, an important caveat here is that any sleep medication will impact sleep in an artificial way. I'd like to mention something which is kind of fun to think about and which is sort of fascinating to my sleep fellows and even to my patients is that while these medications can reduce the time to help you fall asleep and perhaps reduce the time that people may be awake in the middle of the night and to some degree increase total sleep time, and we see this from polysomnogram studies, it's the positive perception or attribution that people have of the quality of the sleep that they remember. What might be occurring is that these medications might seem helpful for improving sleep issues primarily because of their amnestic effects, which create the perception that the sleep quality has significantly improved. You might still be waking up frequently during the night, but the medication could be causing you to forget these interruptions. And as we know, these awakenings can lead to frustration, but the amnestic effects of these medications may mask this aspect of your sleep experience.
I've always found that aspect so fascinating because, in some ways, it explains many things, or did explain many things when I started to realize it, which is that these medications, yes, there are some objective measures that are very clearly improved, that total sleep duration can be improved, etc. That's the reason why the FDA cleared them for this benefit in part. But it's also the fact that subjectively, not objectively, based on fancy sleep recordings, but subjectively, you just quote unquote feel better about the quality of your sleep. And the reason you feel better is maybe not necessarily because physiologically you sense your body to be much more restored and refreshed by your sleep. It's that mentally you have an amnestic timeline of your sleep, meaning you don't really remember the frustrating, brutality of insomnia, of awakenings throughout the night. And so you wake up thinking, well, I don't remember waking up, so it must have been a good night. And so it's a psychological convincing of oneself rather than a physiological sensing of oneself. And the reason I say it was always fascinating to me was not just because of that almost oxymoronic difference between those two. It's the fact that it may explain why you would think, well, if people are sleeping that much better objectively, wouldn't we see many, many physiological health benefits? And there can be many. We're not saying that there aren't here, but you would almost predict even more. So I'm so glad that you bring that up. It's a fascinating component. A partner for today's episode is AG1. What is AG1? AG1 is a nutritional drink, and it contains a whole constellation of antioxidants, biotics, minerals, essential vitamins. It's a long list, but you get the the comprehensive picture, let's say. I've never been interested in fads or quick fixes with diets. It just doesn't work. And that's not what AG1 is about. I've been using AG1 for the past couple of years. I have been using it. And just to note, I do buy it myself. I'm not interested in the idea of freebies for the obvious trappings. But one of the reasons that I've been using it is because I did my research on the science behind the ingredients, and I do place a high priority on scientific data as ground truth. The new formulation that AG1 has, it has over, I think it's 50 revisions and improvements. That's how dedicated they are. And you can try AG1 and get a free 1-year supply of both vitamin D and K2. And for listeners of this podcast, you can also get, in addition to those things, 5 free AG1 travel packs with your first subscription. Head on over to drinkag1.com/Matt Walker. Again, that is drinkag1.com/Matt ag1.com/Matt Walker. Maybe unpack then a little bit more about not just the benefits, but describe the benefits of these drugs based on the conversation we've just had, but also some of the risks of these non-benzodiazepine hypnotics. They are a second wave of drugs, and we typically think of second wave generation drugs to be less risky, have less side effects, but help us understand those potential risks and side effects too.
As I mentioned, the Z drugs or these benzodiazepine receptor agonists, they tend to have a lower interaction profile with other medications as compared to benzodiazepines. They might not affect our sleep architecture by affecting slow wave sleep, as do benzodiazepines. There's less of a concern for withdrawal symptoms or a rebound insomnia as compared to the benzodiazepines. But the risks to using benzodiazepine receptor agonists are fairly similar to benzodiazepines. So there's a risk for falls, daytime drowsiness, cognitive complaints, including attention and memory problems, and like the benzodiazepines or any sleep medications for that matter, impairments in driving and activities that require alertness can occur. So while they're commonly touted as having a decreased risk for abuse and dependencies, I can certainly attest that any medication that you use to alter your experience of reality as a means of escape definitely has the potential for abuse. And these medications, for some people, become a means to escape from the sadness of their lives, which is very sad. Lastly, I'd like to talk about complex sleep-related behaviors and anterograde amnesia. Two side effects of these medications that occur probably way more often than we hear of in the literature. First, let's talk about anterograde amnesia. So, because these medications can impair memory, any behaviors or conversations that you may engage in after you've taken the medication may not be remembered the following day. This isn't too different from an alcohol-induced blackout. While it might sound benign, I can tell you that patients that have had these amnestic experiences feel completely vulnerable. And if they've engaged in some sort of conversation that they can't remember, they can experience a significant amount of shame. The recommendation, of course, is to stop the medication because it can likely occur again.
And what you're saying there, just to be clear, is that people essentially on these medications are engaging in actions, behaviors, and decisions that when they wake up, because of the amnesia, because of the memory loss, they have no sense of any of this having occurred. And so you can imagine, depending on what they did or what they said or what they chose to do, it can be deeply embarrassing, or it can have some significant consequences.
Yeah, absolutely. It's the forgetting of the things that have happened after you've taken the medication, whether it be engaging in conversations or behaviors, which is what we'll talk about now, these complex sleep related behaviors, which for me are both fascinating and can be potentially catastrophic. So, what they are, these complex sleep related behaviors are, is that after taking these benzodiazepine receptor agonists, and mind you, any potentially sedating medication, you may engage in wakefulness like behaviors while partially asleep but not fully awake. These behaviors can include sleep eating, that's a complex behavior, sleepwalking, somewhat complex, engaging in nonsensical conversations, and even sleep driving. And some of these complex sleep-related behaviors have resulted in drowning, carbon monoxide poisoning, sleepwalking in frigid temperatures to the point that led to a loss of limb, and even gunshot wounds. And for this reason, for several of these types of cases, the FDA issued a black box warning in 2019 that anyone who has had a history of a complex sleep-related behavior should be encouraged to discontinue the medication.
I think that position statement, it says so much. It speaks voluminous pitch in terms of what we understand about these sleep medications and the risks. And I know that, of course, people can be taking these medications not necessarily just in a short-term scenario, when you speak to people, they can be on these medications for perhaps several years, sometimes perhaps even several decades. And so I'm just glad that you're bringing this type of stuff to people's attention. Speaking of those types of stories, when you teach your residents at a high level of medical informational dispensation, you don't just do that. You also occasionally add in a narrative story. And I believe there is a story that is autobiographical. Can I ask you, and again, we can include it, we don't have to include it, but can I ask you to share that autobiographical story that I actually know of?
I had to do some thinking about this, but at the end of the day, what we're doing here is to educate people. And what's more powerful than a personal story? And I share this story every year to our sleep medicine education fellows at our teaching center because it really drives home a point. And I believe it helps them remember the potential catastrophic nature of these medications. So I'll start by saying that when I was a resident, we would work exceedingly long hours in the hospital, sometimes exceeding 100 hours a week or 36-hour shifts. This has since stopped, but at the time it was grueling. We would work nights and then have to shift over to days, and that particular transition from working days and nights was really making it very difficult for me to sleep. So, in order for me to feel a semblance of sanity, if you will, to be able to sleep, I requested for my primary care physician a very small quantity of Zolpidem to help me get to sleep when I would come home so that I could get an adequate number of hours so that I can start my shift the next day. And I would say that the medication worked beautifully. I took the medication responsibly. I would take the medication and I would go immediately to bed, and it would reliably help me initiate sleep, and I would get a good number of hours of sleep. No problems. Like you said, I didn't have a problem for the first few days, and why would I expect something to happen again? But, but on one night, I had taken my Zolpidem as I always did and went to bed, immediately to bed. But shortly after taking the medication and falling into bed, I received a distraction, a phone call. And I spoke for a bit, maybe a few minutes, can't really recall. And what I had forgotten was that I had taken my medication. What happened next was pretty bizarre. What I remember was I was last in my bedroom on the phone for a bit. But now I found myself downstairs in my condominium, standing over the kitchen counter, looking at my kitchen counter. It's sort of a blank stare. I can't even really describe it. It's almost ineffable. I mean, it was as if I can take in visual information and other information, but I had no sense of direction or purpose.
Hmm.
It's as if I was in my body, but not really integrating information in the way that I normally would integrate information. The lights were on, but nobody was home, so to speak, right? So as I'm in this dissociated state, scanning this kitchen without any purpose, it felt as if there was a fading out again, as if all of the lights blacked out. The next thing I recalled was driving in my vehicle. And again, I was
Wow.
completely out of it. Yeah, I was somehow operating the vehicle, but having no sense or purpose of what I was doing. Operating my vehicle, it's an automated behavior, right? We do this over and over and over again. It's an overload behavior. So there, on some level, we can do this even while we're partially asleep. And this is how parasomnia sort of engage. And so as I'm driving, I'm looking out the window and not really understanding what I'm doing, what was happening. Again, fade out and then fade in. I'm now getting food from the local fast food restaurant a mile away from my condo at the drive-through. Again, almost as if I was an automaton. There was this dissociation. I was just reaching my hand out of the window, retrieving this food with no emotion, just operational, just automatic. Fade out again, and fade in again. And now I'm back in my condo. The fast food that I had just gotten had been eaten. Wrappers of the food and bits of food strewn all over the kitchen counter. And at this point, which is perhaps a matter of 30 minutes after I had taken the medication and having seen the food on the counter, I soon began to have a sense of what was going on. I remember taking the medication, and bits of what had happened included staring blankly in the kitchen counter, driving automatically to the fast food restaurant. It was almost like flashbacks, receiving food from the fast food worker. All of this came to me. And man, I was just absolutely felt sick to my stomach because I had realized that I had been on a medication and had engaged in this complex sleep related behavior. And really, what was sickening to me was, whether I had somehow hurt anyone while I was
Yeah.
driving.
Yeah.
My heart sank. It was almost like my life was flashing before my eyes, as if someone in the process of this automaton behavior was hurt in this process. And I quickly ran to the car, sobering up, if you will,
Yeah.
quickly looked at the car to see for any signs of damage, which thankfully there was nothing, no scratches, nothing like that. And basically I never took the medication ever again in my life. As I said, man, I mean, I'm pretty hesitant about sharing this story, but I do share it with my fellows, and I think about it as an educator. I really want people to know what the potential risks are, that it can happen to anyone. It can happen even if you've taken the medication safely, and it only takes one time to make a catastrophe occur, even if you've taken it, as you said, for years.
So, first, thank you. Thank you for being brave enough to share it. And it does require bravery for all the reasons that people listening can understand. The second is almost a follow up question. How disturbing was it in the days after to realize the following fact, that pharmacology had removed essentially your own volitional control of you, the human being? Essentially, that's what happened. You
Yeah.
had no volitional control. You have no recollection of making those decisions, of making those choices. They truly were not under your control. Now, of course, heaven forbid, if something had happened, there would be a legal and medical case made that would ask the question, well, how do we think about that? Because obviously the medication was causing that non-volitional behavior. But at another level, you can say, well, if it's not Ranji's fault, if he's not culpable, then who is? He was clearly doing these things. I should speak with another one of our fantastic colleagues, Carla Schenk, about all of this legal medical interaction space between the world of sleep and legality. But how did it feel in the days afterwards, having had your volitional, willful control taken away from you and pharmacology, something else, take over you?
By the way, there is a whole field of sleep medicine dedicated to this called sleep forensics, which originated at the Minnesota Regional Sleep Disorder Center by Dr. Mahowal, Dr. Schenk, and Dr. Mish Kramer-Borneman. And there are some very widely publicized forensic cases about Ambien, but also non-REM parasomnias that can induce these sort of behaviors with the person engaging in these wakefulness-like behaviors, but without the necessary will or the volitional. So how did I feel?
By the way, some of those are absolutely tragic. I mean, perhaps one of the most famous is the case of Kenneth Parks
Yeah.
and what we now come to understand as a term called homicidal somnambulism. And not to take us off from that, but just to come back to your thoughts. Yeah, how did it feel in that regard?
Vulnerable. I felt absolutely vulnerable and ashamed and sad, to some degree angry, but I think the word really is I felt vulnerable. I felt like I had no control over what I was doing, and it put me in a very vulnerable state. I mean, it put others as well, but it put me in a very vulnerable state. And that persisted for several days until my fascination started to emerge. That you're correct, that pharmacology had induced this dissociated state and engaged me in these behaviors without me really wanting to engage in this behavior. Perhaps there was a primitive circuit within me that was looking for food, but I wasn't hungry. And so it really started to even make me fall in love with sleep even just a little bit more because, this is just another example of how consciousness is fluid. Consciousness is not this binary experience of being on or off. It's sort of a spectrum. It gave me a little bit of fascination, and again, this sort of made me fall in love with these non-REM parasomnias and these non-ordinary states of consciousness that sometimes psychedelic medicines can induce. So yeah, fascination and terror, if you will.
The peculiar, the many, the varied ways that we all start to fall in love with this thing called sleep. I have to say, that's about as novel as they come, my dear fellow. That is up there in terms of the ones that I've heard of. So with that, I think we will draw close to this episode, but folks, do not worry. We're going to do a follow-up episode because this story of sleeping pills is not even close to being finished. We've spoken about the first wave of sleeping pills, the benzodiazepines, and then we followed up by speaking about the second generation non-benzodiazepine hypnotic medications. But there has now been a raft of emerging both what we call off-label prescription medications for sleep and also some new emerging medications for sleep, a new class of medications that do work collectively, because there are several of them, in really some fascinating, completely radical and very different ways to these benzo and non-benzo drugs that go after this GABA system that we've spoken about. So where can people find and follow and learn all about you and the work that you're doing? Websites, social media handles, etc. And we will, of course, put these in the show notes too.
Well, I'm on Instagram at DOC Varghese. I'm on X again at DOC Varghese. I'm on LinkedIn. Reach out to me at hennepinhealthcare.org. I have my clinical psychiatry practice at iit-mn.com. I'm not a big social media guy, Matt, but I like to be available for people when they need help.
Ranji, for now, let me draw this to a close. Let me thank you again for sharing all of your knowledge. You are just both brilliant in communication, but also encyclopedic in knowledge, and your years of clinical experience shine through. So thank you for helping us understand and navigate this really complex and at times quite prickly world of sleeping pills. Thank you.
Absolutely, Matt. Thank you again for allowing me this platform to spread some education. So thank you very much. It's been a privilege.